Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the Health Matters Comprehensive Chat by the Islamic Medical Association. Our slot has moved to the Saturday afternoon in the Ramadan, and Ramadan Mubarak to all of you, and may you have a very spiritually elevating month. It's the first of our Ramadan show, so it'll be every Saturday between 15:30 and 16:30, 3 to 4 in the afternoon. And today we are very honored to have a guest in the form of Dr Muhammad Barmania, a urologist in private practice at the Donald Gordon Medical Center in Mill Park. Assalamu alaikum, Dr Muhammad.
Wa alaikum assalam wa rahmatullahi wa barakatuh, Yakub, to you and to the viewers out there. And thank you for inviting me.
Alhamdulillah, alhamdulillah rabbil alameen, wal aqibatu lil muttaqeen, was salatu was salamu ala ashrafil mursaleen, Sayyidina Muhammadu wa alihi wa ashabihi ajma'in. Today we will read our tarbiyah in the form of a ayah that is being read very frequently for Ramadan, which is Surah Baqarah, verse 185, which starts with Shahru Ramadan al-Ladhi. And Allah says, Ramadan is the month in which we send down the Quran as a guide to mankind, also clear for guidance and judgment. So every one of you who is present during that month should spend it in fasting. But if anyone is ill or on a journey, the prescribed period should be made up by days later. God intends every facility for you. He does not want to put you into difficulties. He wants you to complete the prescribed period and to glorify Him in that He has guided you, and perchance ye shall be grateful. The Mufassireen and the ulama have obviously interpreted this and given various angles to this for our benefit. But for tonight's program, obviously, there's a portion mentioned there that if you are ill, you could make up on it. And today we're talking about illness. And we're going to be talking about renal stones, renal calculi, and urinary incontinence. Muhammad will tell us perhaps if it impacts on ill health to the point if it affects your fasting or not. But again, the gist of it is that Allah has catered for all of us. So even while you are ill, Ramadan is a spiritual month where you can be grateful, you can make up for it, or obviously there are rulings for those who can't make up for it. And may Allah guide us all, inshaAllah. Our topic today, Muhammad, urinary stones and incontinence. We'll go in order. We'll start with the stones. Medical term, urinary calculi. Many times patients come to us and tell us, Doctor, I got stones. And they're not quite sure what they're referring to because they point around the abdomen area. And it could be in the upper part of the right abdomen, and then again could be referring to the lower back. So there is confusion sometimes with gallstones and kidney stones. And I don't know if you could maybe just clarify on that.
Okay, for starters, basically, we're speaking about kidney stones. You can get stones, more correctly, stones in the urinary tract. You can, as you said, you can get stones in other organs, and what we do get is gallstones. So in terms of kidney stones, both your kidneys are situated in your flanks, in your upper back on either side, and you have drainage tubes which are called ureters that drain each kidney into the bladder. So if you have stones in the kidney or in your ureters, the pain can be quite variable. Most of the time patients would complain of upper back or sometimes lower back pain, or what we'd like to refer as flank pain. And often if the stone's in the ureter, you might find that the pain will radiate down into the groin. With that, they might notice that there might be blood in their urine sometimes. If they don't notice any blood, if a doctor checks their urine, then there might be blood microscopically in the urine. The other thing is sometimes when you get stones low down in the ureter, that's a tube between the kidney and the bladder, patients might have what we call voiding symptoms, symptoms with passing urine. They might feel that they can't pass urine, or they go very often to pass urine. So the symptoms are often not clear-cut. Because chronic back pain per se is so prevalent in society, many a times patients have chronic back pain from degenerative arthritis in their lower back, and often they would present to you to basically to clear their mind that they don't have kidney stones, or they might have spoken to someone and they might have warned them or advised them to check out if they don't have any kidney stones.
Okay, so Mohammed, you've actually taken my next question and answered it already as to how would patients recognize that they may be having stones and seeking help in terms of symptoms. But just tracking back a little bit to the point that, look, it's a common condition. How common is it? Because we always say, kidney stones are kind of common.
It's fairly common. If you look at the lifetime risk of getting a kid, firstly, it's more common in men than.
Slide 1 will come up. It was in the background. Okay. You can just show a bit of the epidemiology.
It's more common in men than women. The incidence of kidney stones in men is approximately 13 to 14%. So that equates to about 1 in 7 men will get a kidney stone. With females, it's a bit less, approximately 7%, which is about 1 in 14. In terms of basically the risk factors, and the epidemiology, there's genetic predispositions, there's specific people that have specific conditions that might be predisposed to stones. And then there's other issues like geography, where people live. If you live in warmer climates, in the tropics, in deserts, there's seasonal associations. Obviously, in the warmer seasons, basically there's a higher incidence, and there's dietary associations. I think it's important to consider all these things, because we live in this instant world, often patients want that one thing that's causing their problem. And more often, it's rather than one thing, it's a multitude of factors that co-opt and together basically increase your risk for any disease.
Okay, there's a few points from that slide that I just want to take up. You mentioned genetics. So does it occur in families?
Okay, it does occur in families, but not per se. Well, there's certain type of stones which are not very common. So things like cystine stones or xanthine stones, there's definite straightforward inheritance patterns. Things like uric acid stones, obviously you get families that have a high incidence of gout or high uric acid, and they will have predispositions to stones. The other thing is, because often families are exposed to similar environmental factors, those environmental factors might predispose many members of a family.
Okay, so that's mainly from a multifactorial point of view, but the genetics. So you mentioned xanthine and that but those are not very common.
Those are rare stones.
Right. Is there anything that people that are predisposed to that particular genetic profile, is there anything they can do?
I think the only way you'd pick it up if someone in the family has a stone, or they might have many stones, and when someone analyzes the stones or do a metabolic workup, because one of the things in terms of our treatment is that if you can get a stone, so you can analyze the stone, because then you know what you're dealing with. Because the different stones, the modalities, there's no one size fits all. The different stones, basically, there's different interventions that you could do.
Okay, we're going to come to types of stones just now, but going back to that first slide again. You mentioned diet and water intake. It's Ramadan now. People are dehydrated. Do they have a higher risk? And to what extent is that risk, and can they do anything about it?
Okay, I think definitely, basically, they are at increased risk. The simple analogy about the formation of stones is that you get these salt crystals in your urine.
Slide 2 will show something like that, the mechanism.
And basically, depending on the constituents of the stone, so it could be calcium, it could be oxalate, it can be citrate, and then you get other things in the urine that prevent stone formation, the citrate and magnesium per se. Going back, the constituents can be calcium, oxalate, uric acid. So what happens is these crystals are basically in the urine. Now when the concentration of these crystals get too high, the crystals join and they form stones. I like to explain it to my patients in terms of, if you take a glass of water and put a teaspoon or tablespoon of salt or sugar and you stir it, it will dissolve. You add a second, third teaspoon, it will dissolve. But by the 5th or 6th one, you'll see the crystals form. I also like to call it the anthill effect, you know. You get many millions of ants, each one brings a little few sand grains and basically it joins. So similarly, what happens is, so the more water you have or the less concentrated your urine is, the less likely basically is you are for these crystals to get bigger and join and to evolve into a stone. So obviously in Ramzan, because we're fasting, we're drinking less fluids in the day, your urine is going to get more concentrated, and because the urine is going to get more concentrated, the concentration of these these salts are going to be higher, and that's going to evolve into stones.
So people that are fasting, different age groups, you mentioned the age group of 20 to 40 at the highest risk. How often do you see stones outside those age groups? So those particular age groups, you're encouraging them to drink more water and make sure that they're a bit well hydrated. But generally all people should hydrate themselves.
Sure, all people should hydrate themselves. We see stones across the spectrum. From kids, the other day I saw a 5-year-old, to much elder patients. I think when patients are more frequent, like kids, if you have kids with stones or patients present more frequently, then you need to look for underlying risk factors, or what we like to refer to as metabolic disorders. Going back to your question about how, in terms of Ramadan, basically how you could prevent it is, I advise my patients is just to make a conscious effort at Sehri and after Iftar to increase their fluid intake. Ideally, patients with kidney stones, we want them to pass about 2 to 2.5 liters of urine a day. Okay. And to get that sort of output, you need to be having
a lot of water.
3 liters plus of fluid.
Fluid, water only, because people tend to drink lots of different things in Ramadan, the faludas and the milkshakes. And
I think fluid is fluid, it will be beneficial, but water is better. I would suggest to avoid the carbonated drinks, but fluid, but generally any sort of fluid. The simple analogy I tell my patients is that every time you go and pass urine, you must look at the urine and it must be on the light side of yellow. If it's on the dark side of yellow, then basically it means it's concentrated and you're behind on fluids.
Okay, no, Jazakallah for that. That's a very good introduction. So in terms of the stones, how are they formed?
Okay, so as we mentioned...
I mean, you discussed it, but in terms of linking that up with the different types of stones.
Okay, so it basically...
Slide 3.
So it basically depends what you're excreting in your urine. So people that excrete excessive amounts of calcium in their urine would tend to form calcium stones, and that would join with either oxalate or phosphate, or there's other salts also. Some people basically excrete excessive amounts of oxalate in their urine. It could be people that, it could be in their diet. Things like excessive amounts of Worcester sauce has been shown to have oxalate. Rhubarb, with the bariatric surgery in vogue, where people have surgery to basically lose weight. People that have intestinal bypasses, or some people that have short intestines for whatever reason. Those patients have increased oxalate excretion in their urine. In terms of the uric acid, people with high uric acid levels basically get gout. They also can get kidney stones. But the surprising thing is people with a high uric acid, more often than getting uric acid stones, they tend to get calcium oxalate stones. And the reason for that is that the uric acid acts as a skeleton for the calcium. So the uric acid acts as a skeleton, and the calcium gets laid onto the uric acid, and they form the calcium oxalate stones. Okay, so by far the commonest stones are calcium oxalate. There's variants, you get calcium oxalate monohydrate, dihydrate, and then we see uric acid stones. But by far the most common calcium oxalate. The cysteine and xanthine stones, and there are a few other different types of stones, those are less common.
Okay, Jazakallah for that. We're going to take an ad break, inshallah, and then we'll see you after that. Assalamu alaikum. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat by the Islamic Medical Association, the first of our Ramadan programs live on Saturday afternoon. We have Dr. Muhammad Barmania, a urologist from private practice in Johannesburg, here with us. We started an introduction into urinary calculi, which is stones in the kidney that many people refer to, but it can be other parts of the urinary tract system. And he's mentioned a few things about how it's formed and the kind of symptoms you may experience. And I want to take the discussion from there. But the lines are also now going to be opened. So please do call in for any questions you may have on this particular topic. And the number to take is the new number that we have here at ITV. The direct studio number 011 086 7777. It'll appear at the bottom of your screen also. So 011 086 7777. So Mohammed, while we're waiting for the people to phone us, you mentioned in the beginning the kind of symptoms that patients may present with, but obviously you have a method in which you want to diagnose stones. So they're going to come with the pain in the back or maybe in the groin area, a bit of blood in the urine they may or may not see. And the pain can be quite intense. Right. So
yeah, the pain can be quite severe. Often
people have compared it to like labor pain.
Oh yes, the woman won't say it's as bad, but it's a close second, I would say.
Yeah, okay, so that's a significantly high scale pain. But what other ways than what you do? You got your patient, what diagnostic techniques do you use to make the diagnosis?
Okay. So basically, it's firstly, as we mentioned, it's with the symptoms and what the patients complain of. Maybe they've had a previous history of stones. It's firstly clinical suspicion. On the examination, most of the time, you know, other than their obvious pain, there won't be too significant findings. Then we would examine the urine to see if there's any blood, which we may or may not see, because sometimes you can get kidney or renal tract stones without blood in the urine. So it's basically our clinical suspicion. As urologists, most of us would have ultrasounds in our rooms, and we would do an ultrasound of the kidneys. And if the stone's in the kidney and a reasonable size, you should see the stone. Occasionally, because ultrasound is a very operator-dependent test, sometimes you might not see the stone. If the stone is in the ureter, I think if they can pop up slide 4, it will just give the viewers an idea of the anatomy. If the stone is in the ureter, so that's the anatomy of the urinary tract. The proportions with the blood vessels are not totally correct, but what we want to show there is that you have 2 kidneys, and then you have a ureter that drains the urine from either kidney into the bladder. Now that ureter is about the diameter of a drinking straw. So it's a fairly small tube. So the point I was trying to make, that with an ultrasound it will be difficult to see stones in the ureter. But what you might see is indirect signs. If that ureter gets blocked by a stone, what happens is that the tube above it gets bigger, it dilates. And the kidney also dilates or balloons up. We refer to it as hydronephrosis in terms of a medical term. So on the ultrasound, you might see, you may or may not see hydronephrosis or dilated kidney if they have a ureteric stone. Occasionally, sometimes we do the ultrasound and we don't see anything, but it's our clinical suspicion, and then we would send the patients for further tests. And the test basically we do today is a CAT scan without contrast, without dye. It's a fairly quick test. It takes about 10 minutes to do, which gets done in the X-ray department. And the CAT scan will pick up almost all stones from the minutest, like a millimeter or less even upwards. So a CAT scan basically is the diagnostic modality of choice.
Now the scenario where patients go to the primary doctor, the GP, or the suspicion, wherever they may be, before they get to you. From a perspective, I know a lot of GPs are also watching the program sometimes. Does the GP send them for an ultrasound if he's very worried, immediately to the radiologist? But sometimes you guys are a bit busy, and to get a hold of you chaps, maybe you may be in theatre or something of that nature. Patient is in a lot of pain, you want to get a diagnosis. Because I know with the gynecologists, they seem to be better at doing the ultrasound than the radiologists, with due respect, because they see the fetal anatomy more often. Is there a value in sending them straight to the X-ray department? And if they don't then see it on the ultrasound, do the CAT scan immediately? Not that I'm punting business for you kind of thing, but I just want to check what's the best for the patient, convenience and that type of thing.
To expedite
the
matters.
process, yeah.
I think if your clinical suspicion is high enough that the patient has a kidney stone, and or even if the patient has a history of previous kidney stones, which would make it easy, then my suggestion would be to skip the ultrasound and just request a CAT scan. Obviously, from a funder's point of view, that brings up a whole other issue.
The medical aids,
because the medical aid sometimes might have an issue with the general practitioner requesting a CAT scan. But many a time, from time to time, I get patients referred and their GP has requested a CAT scan. Because from our side of things, we're not going to manage a patient on an ultrasound.
Yes.
Even though the ultrasound might show a kidney stone, there might be a second or a third stone in the ureter, or a stone that possibly the sonographer has missed. So even if there's a positive ultrasound finding, we won't intervene without a CAT scan. So the answer is yes. If you think that you have a high degree of suspicion that it's a stone, then I don't think it's unreasonable to send the patient directly to the X-ray department to have a CAT scan without contrast, and then you definitively have a diagnosis. And the advantage of a CAT scan is that sometimes it might show up other pathology, things like appendicitis or cyst in the ovaries or other inflammation.
Yeah, and that's if it's not a stone, because those things can mimic the pain.
Yes.
So you may be having, so you're actually getting to a more specific diagnosis and getting to the root of the problem quicker and faster.
That's correct, Yakub.
All right, the lines are open, 011 086 7777. Please do call in. You've got any questions relating to? We do have a caller. Assalamu alaikum. Assalamu alaikum.
Wa alaikum salam wa rahmatullahi wa barakatuh.
How are you, brother? You can go ahead with your question.
I just want to ask about if you have a problem with the urine, non-stop urine, is it have to do with the kidney problem?
Assalamu alaikum wa rahmatullahi wa barakatuh, brother. If I get your question correctly, you want to know if you're going very often to pass urine. Is that correct?
Yes, yes.
Okay, and is that only in the day or in the night?
During the time, during the day, I think.
Okay, and how old are you?
I'm 31 years old.
Okay. Do you have any other symptoms with the urine? Does the urine come out slowly, or is there a good stream? Is there any burning when you pass urine?
You know, the problem is that when I go to the toilet, I'm passing urine. It stops. Then when I've cleaned myself, then it starts again coming out.
And when you say it starts again, is it just one or two drops or a few drops?
Drop.
Okay.
Yeah, some drops. The drop doesn't stop.
Okay, and then do you notice that after a while you get concerned that maybe there's a few drops that came out on your underwear and you're worried about being park or not park?
Yes, that's exactly.
Okay. Yakub, this is a very common, I think we're going a few steps ahead what we were going to discuss in the incontinence part of the discussion. I think if we can go to slide, I think it's 14, the male anatomy one, and maybe that will help. So basically what happens is that this is a common problem we see.
Slide 12.
It's often in Muslim male patients, and basically what happens is that they pass urine, and then after a while they might notice a few drops that come out.
Yeah.
We call it like post-void dribbling, or dribbling after passing urine. Now if you look at that that picture of the anatomy, you see the bladder there,
Okay.
and below the bladder you see what's called the prostate. Now just below the prostate we have a valve, or we refer to it as a sphincter, that controls the urine. All right. Now that valve in a resting position is closed, so we don't leak urine, we don't wet ourselves. So when you pass urine, that valve relaxes and you're able to pass urine. But what happens is when that valve closes, there might be urine left in the urethra, in the part of the urine tube that's in the penis. Now Allah in His wisdom knows why the sphincter is below the prostate and not on the tip of the penis. So what happens is sometimes some drops of urine are in the urethra, and when you stand or you get moving, then that urine it's released. So what we advise our patients to do is, one is what I tell them to do is to double void, to pass urine twice. So finish passing urine and then wait a few seconds and pass again. And the other thing is we suggest is that they must milk their, once they finish passing urine, they can just milk their urethra, the bottom of the penis, just milk it forward, so those excess drops, if there are any, that they come out. But it's nothing pathological that's wrong with them.
Okay, brother, so what doctor is saying that it's not anything to worry about, it's not a disease, and I hope that answers your question, inshallah. I believe we have another caller. Assalamu alaikum wa rahmatullah.
Assalamu alaikum.
Wa alaikum salam.
My name is Ibrahim.
Ji Ibrahim, go ahead with your question.
Okay. Assalamu alaikum.
Wa alaikum salam, Ibrahim.
Doctor, I did the laser in a garden to Professor Hafizi for the kidney stone.
You did an operation?
Laser.
Yeah, I did a laser.
Oh, laser, okay.
Right. Now it's only the week, and I'm fasting. So is there any dangerous or anything?
Sorry, Ibrahim, I didn't get that last part. You said it's only a week and then?
Only the week I did the laser.
Yes.
Right. Now I'm fasting, right?
G.
Oh, he's fasting.
Okay. Okay, Ibrahim, we do get the question. Have you had stones before, or there multiple stones?
It's when I went in, and he found one side is 8 stone and one side is on the right hand side is a 8 stone. So Dr. Professor Hafizi, he did a laser for me.
Okay. Okay. Ibrahim, I don't think it would be it shouldn't be a problem with you fasting, because alhamdulillah the fasts these days are quite short, and the other thing is it's not very warm. What I would suggest is you make a conscious effort that at Sehri and after Iftar to have extra fluid, so that within that 12 hours that you're allowed to eat, that at least you can have approximately 3 to 3.5 liters of fluid.
Jazakallah Ibrahim for your question, and may Allah make it easy for you to recover from it, and inshallah Allah accept your fast. We're taking an ad break inshallah now, and then we've got quite a few calls coming in, so please just hang in there and we'll see you shortly. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters IMA's program. Comprehensive chat. We're discussing urinary stones. Dr. Muhammad Barmania with you. We have a caller, so please we can go ahead with that call. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum.
Wa alaikum salam. Doctor, I'd just like to find out. My husband passes a lot of urine at night. So, I don't know if you can help us please.
Sister, assalamu alaikum wa rahmatullahi wa barakatuh. How old is your husband?
He's 58.
Okay. And does he complain of any other symptoms, that is the urine slow, or he goes often in the day, or he's got to plan his day around the toilet?
No, not really. He goes normal to the toilet.
Okay.
But he has a lot of water to drink.
Does he have any other problems like high blood pressure or heart failure or diabetes?
No, he's got pressure and sugar.
Okay.
He's on medication.
Okay.
But
And is
which is controlled.
his
Yes.
sugars controlled? All right.
Yes.
Okay.
But the urine that he passes is mostly at night. He wakes up sometimes 4 or 5 times at night,
okay.
you know.
And no doctor has ever told him that he's in heart failure, or does his legs swell up during the day?
His legs does swell up. In fact, he doesn't have very much feeling on the legs now.
Okay.
So the fact said it was because of the sugar.
Okay. Yeah. So the fact that he doesn't have too much feeling in the legs suggests that, you know, the sugar has been quite severe, or it might not have been well controlled, or it's been long standing. We refer to that as a neuropathy, that the nerves don't work so
Diabetes,
well. So and the swelling of the legs can basically suggest that maybe the heart's not pumping as well. There might be a mild degree of heart failure. Okay. So I think moving forward, in the potential causes of going often at night could be either medically related causes, or it could be related to the urological system or the urinary tract. In terms of medical causes, you know, because your legs swell up during the course of the day, when you're lying down at night, what happens is that swelling decreases. We refer to it as third space fluid. And what happens, that fluid gets into the blood vessels, and because more fluid gets into the cardiovascular system, as we'd like to say, then the kidney perceives that there's more fluid, so you make more urine. So that's one possible reason. The other possibilities could be considering his age and other medical problems, is prostate issues, which always come into an equation. And then the other problem could be a bladder problem. Because of the diabetes, sometimes the bladder doesn't work so well. So my suggestion is, if his general practitioner or his physician is happy that his blood pressure and his diabetes is optimized, then my suggestion would be to see a urologist, because he would need an examination and an ultrasound. We need to see how well he's passing urine, whether the flow is good, whether he's emptying his bladder adequately. Are there any other issues, like maybe infections? But infections, you would expect some symptoms in the day also. And based on what our findings, then inshallah there should be medication that we'd be able to put him on, and he won't go as often at night, and then he can have a decent night's sleep and he won't be as cranky in the day.
Okay, sister, so you got that, inshallah. We have another caller. Assalamu alaikum. Assalamu alaikum.
Walaikum salam.
Ji, sister, can you go ahead with your question?
Okay, my husband also has a problem with urine acid. What could be the problem with that? His urine also burns a lot.
Assalamu alaikum wa rahmatullahi wa barakatuh, sister. How old is your husband?
He's 40.
He's 40. And any other issues, diabetes, high blood pressure?
No.
Okay. And other than the burning, does he go often in the day and the night, or only at night?
He goes both day and night.
Okay. Any infections elsewhere? Does he get any infections anywhere else?
No, it's just a bladder infection which he gets, and he takes antibiotics and fish soda just to relieve the burning.
Okay, and he's been treated for many bladder infections over the time?
Yes.
Okay. Sister, he's a 41-year-old, or he's a 40 or 41-year-old gentleman that's relatively young, alhamdulillah. And you know, infections in young men are not so common. And if he's been treated for repeated infections, you know, one would always look, is there an underlying cause? Common things we would see is sometimes there might be a stricture, which is a narrowing in the urine tube. There's other things, sometimes people might have stones, like a bladder stone for some other reason. He might not be emptying his bladder adequately. So my recommendation would be that he see a urologist and he get assessed, because this is not it's not normal.
So the suggestion is not to continue taking antibiotics and just treating it and clearing it, but now to take it further, sister, and to see a specialist urologist, Please go ahead and try and get that done as soon as possible, inshallah.
Yakub, just on that point, the recurrent infections, or even with any other disease, if you have a problem and you're being treated or getting antibiotics, be it for a pneumonia or a urinary tract infection, and it keeps recurring, then the question always arises, is there an underlying cause that predisposes you to those infections?
That's right.
And that's why you should have it checked out.
And not just to treat the symptoms. Yeah. Okay, Jazakallah, sister, and have a good Ramadan, inshallah. We have another caller. Assalamu alaikum. Assalamu alaikum. Salam. Go ahead with your question, brother.
Yeah, brother, see now you're in the month of Ramadan and you're fasting. So, brother, I wanted to ask you, I got problem of pain, thoroughly pain, headache, continuous thoroughly pain of headache. So,
brothers,
sorry, your line is not clear, brother. Can you just repeat the question?
Yeah, brother, I wanted to ask you, I got a problem of my forehead and the neck, because pain thoroughly pain. Repeatedly.
You got pain in the forehead and in the neck, brother?
Yeah, pain.
Yeah, but
I don't know.
Yeah, brother, we're discussing problems with the kidneys and the stones. The specialist that is here is discussing kidney stones and problems with urine and to do with the kidneys. So if you've got other issues, so you should consult your doctor with your headache and your forehead pain. Inshallah, then you can just get it attended to. Assalamu alaikum. Okay, we have another caller. Assalamu alaikum.
Hello.
Hello, you can go ahead with your question, sister. Assalamu alaikum.
Doctor. Hello. I just want to find out that I've had the. Walaikum salam. Doctor, I'd like to find out is that I had my womb removed some years ago and one ovary. But now I've been having a lot of infection, and I have been taking Ciprobay or Ciplox and things like that, which normally controlled it. But lately, it's about 2 months that I noticed that I have a funny feeling, and I seem to be passing urine now and then. Like it's different now, more often now.
Sister, assalamu alaikum wa rahmatullahi wa barakatuh. From what you're describing, basically you're having frequent infections in your urinary tract or in your bladder, what we refer to as cystitis, and you've been taking antibiotics, and you mentioned ciprofloxacin, which is one of the antibiotics that we use. On the point of infections, the first thing about an infection is that I think the first thing we need to do is document the infection. Many a times people think they've got an infection, they go to a pharmacy or they get access to antibiotics, and they take antibiotics because they think it's an infection. From time to time, patients see general practitioners and they might notice blood in the urine or some pus cells and treat them for an infection, and then they get an infection again. That's quite reasonable. But my general practice is, if you're getting a recurrent, what you think is a recurrent infection, is that to document it. And how we document it is basically we culture the urine. So you send a urine sample to the lab and they tell you for sure whether there's an infection or not. They would culture a specific bacteria, and more importantly, they will tell you what antibiotics work for that bacteria. The problem with widespread antibiotic use is that these days we are culturing very resistant bugs, very resistant bacteria. And the conventional antibiotics that we used to use or still use to treat infections in the urine are not working any longer. And often patients need to be admitted to hospital and given antibiotics in the drip. So that's the one issue with the infections.
So are you saying to sister now that she must get her urine checked?
I would suggest
formally a proper urine test in the lab.
That's correct. I would suggest to see a general practitioner and tell them that you've had multiple infections, can they please just culture your urine to make certain that there is or there isn't an infection? The other thing I would suggest is that because you've been taking antibiotics, I would stop the antibiotics for 3 to 4 days before doing the culture, because the antibiotics might mask any organism in the urine.
Okay, Jazakallah sister, I hope that answers your question. We're going to take an ad break again, and then we do have calls again. So inshallah we'll see you shortly. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat by the IMA, Islamic Medical Association, discussing urinary stones. But we've got a urologist in our studio, Dr. Muhammad Barmania, and we are taking calls. So we have a caller on the line. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum. Okay, so we were discussing some issues about the stones. I don't think we're going to get to urinary incontinence with the time limits, but we've already had some questions around that, so it's been a fairly broad discussion. A lot of urinary symptoms. A very concerning one is the brother who found, his wife found the 40-year-old young male. Again, you want to just reiterate the importance of a young male with urine symptoms. Age group maybe under 50, they should seek help sooner, and not just go for just treating their symptoms with citrus soda and things like that.
That's correct, Yakub.
Is that true, right?
Yeah, definitely.
Okay. All right. So in terms of the treatment factors with stones, slide 6 will perhaps tell us what kind of treatment factors you look at, treatment approach. Okay. But you can start and just start with.
Okay. So basically the first thing we said is basically you need to make a diagnosis. So with the CAT scan or a CT scan, you would have diagnosed the stones, and how we take it further will depend on a few factors. I think it's the next slide. Yeah, and basically the factors that will determine what we do is basically the size of the stone, the position of the stone. Sometimes the patient's anatomy, they might have what we call congenital problems. They might be born with conditions that predispose them to stones. Common things are things like what we call a PUJ, or a pelvic-ureteric junction obstruction. And basically what's that is that the drainage of the kidney is not so good. So generally based on those factors, we will decide whether we can treat the patient conservatively, meaning that can we give them a chance to pass their stones, or whether they would need some sort of surgical intervention. Generally when we look at the size of stones, stones under 4 millimeters in size have a good chance of passing on their own. Above 6 millimeters, the chances are slim. Between 4 and 6, it's a bit of a gray area. So firstly, the size of the stone and also the position of the stone. The lower down the ureter, the tube that we showed in the anatomy, the more likely basically it would pass. So if you have someone with a small stone, his symptoms are not very severe, you can control the pain with pain medication that he can take orally, then you can try a trial of conservative, or what we refer to as medical expulsive therapy, where we use medication to try and get them to pass the stones. Patients always ask, is there anything that you can give me that can dissolve the stones?
Yeah, that's a very common question.
Yeah. Unfortunately, in most case scenarios, not. The problem is that with the CAT scan, we don't have a definitive way of saying what the constituents of the stone are.
The type of stone.
What type of stone it is, unless maybe the patient has had previous stones. If we know for certain that it could be a uric acid stone, then if you alkalinize the urine, if you like things like citrus soda or potassium citrate, then that would help the stone to dissolve. But unfortunately for the rest of the stones, we don't have anything to make the stones dissolve.
But shouldn't you just give everyone citrus soda?
No, because
Why?
sometimes it can make some stones worse.
Okay, that's very important, and I think people need to know that.
Yeah. So it can make some stones worse, And then the other thing is, rather than citrus soda, which is sodium citrate, we prefer to use potassium citrate.
Okay.
The reason is that the sodium part of it can increase the calcium excretion in the urine. So we would suggest, if you use an alkalinizer, to use potassium citrate. So, and the citrate, what that does is it makes the salts more soluble in the urine.
So now do you want to tell viewers potassium citrate, where to get it from?
Okay, potassium citrate is a big problem. The main way that it's available is in a syrup form. The problem with it is that you got to buy it by the liters if you're drinking sufficient amounts. There is someone bringing potassium citrate tablets that are available. It's marketed under the name of Potsilite, and it's 1 tablet 3 times a day. So in someone with like a uric acid stone, you could alkalinize the urine. But for the rest of the patients, we're not saying to take alkalinizers across the board. You might need it if you've proven that someone has high calcium excretion in their urine, then those patients might need it. But we wouldn't advocate that across without knowing what stones the patient had or having what we call a metabolic workup. I won't advocate that.
Now, in terms of the decision you make, you're looking at the size. The one I want to pick up on is the 4 millimeter to 6 millimeter one.
Yes.
Because that's a bit of a grey area. Yes. So do you keep the patient admitted and observe, or do you still send them home on conservative medical therapy, trying to flush? Because they could obviously get worse.
Okay. Basically, I discuss the pros and cons with the patient. And at the end of the day, they make an informed choice. Depending on how symptomatic they are, where the stone is, if it's higher up in the ureter, then I tend to be more aggressive and recommend surgical intervention. Obviously, the end decision is the patient's. You might recommend surgery, but it's their option to refuse. So based on experience and their symptoms and the position of the stone and the anatomy, if it's like a 5 millimeter stone and you have a small petite person that's like 50 kgs, obviously the anatomy is smaller, then I would suggest surgical intervention.
So you individualize the treatment based on...
And often patients, as I said previously, we lived in this instant world. People just, many a time, you might get a patient with a 3 or a 4 millimeter stone that you offer conservative treatment. But they say, doctor, just sort this thing out, because they want to get on with life.
Okay. And the fact that it can recur, it's also a fear factor within them that it will come back. And when do you decide between the different surgical modalities, laser and open surgery?
All right. Basically, it depends on surgical expertise first. And the other thing is the availability of equipment. Now, in our scenario in the South African context, we very rarely do open surgery for stones. And that's because of the availability of equipment. If you look at the rest of Africa, north, except for Egypt, far North Africa, there's a problem, because most places they don't even have access to a scope that you can look into the bladder or look into the kidney. So there often patients land up patients land up having open surgery, and many a time it's not even a urologist, it might be general surgeons that manage the urological problem. So in our scenario, the most of the time basically we would use some sort of either a laser or external shockwave lithotripsy, which is not a laser, but basically it's like a sort of jackhammer that we use to pulverize the stones. We'd use some sort of endourological intervention. Sometimes it might be a multitude of interventions, and depending on the number of stones or the size of the stones, it might be more than one procedure, and that might be with or without stents. So it's very individualized. But basically we would discuss it individually with each patient, listing the pros and cons of each intervention, and then make a choice.
And the recovery period will be based on the type of intervention you've chosen. But in average, what have you found in terms of recovery, getting back to work, getting back to normal life?
Most of our patients, basically, if you would do a procedure, it might be a day procedure or overnight stay in hospital. Sometimes with the more complex procedures, it might be longer. The other problem with stones is that you can get infections that coexist with stones. And if you get an infection in the urinary system with a stone that blocks the kidney, that can be potentially life-threatening. So in that scenario, if someone comes with a stone and the kidney is blocked, then the focus is not the stone. The focus is to unblock the kidney. So what we will do is, the first thing is maybe put in a stent to unblock the kidney and treat the infection. And once the infection settles, then address the stone. So most patients, basically, you know, it's an overnight stay. After 3 or 4 days, they might be back at work. But what they may have is they may have urinary symptoms, you know, because of the intervention. They might have blood in their urine for a few days. It might burn. They go often to pass urine. And sometimes with the interventions, we insert stents. A stent basically between the kidney and the bladder, which basically keeps the kidney unblocked, and maybe after 2 or 3 weeks, they might have a second procedure, or we might just remove the stent. The stents sometimes can cause discomfort to the patients, meaning that they go often, it burns, there's blood in their urine. So, you know, it's quite, most patients, you know, beyond a week, about a week, they should be fine to get back at work. But sometimes when they have stents in, it might be a bit more debilitating, and patients tolerate the stents differently. Some patients don't tolerate stents at all. And the patients with the recurrent stones, often when they come back, you know, they'll sometimes tell you, whatever you do, don't put a stent.
Okay. Jazakallah Muhammad, we've almost run out of time. We've reached the end of the program within the next few seconds. Jazakallah khair for coming through. I think it was a very informative program. We will obviously expand on it. We wanted to touch on incontinence and other issues today, but we'll do that on another day, inshallah. Jazakallah to the viewers for the calls and participating. We hope that we've been able to guide you with some of the questions that were answered, and the knowledge and the information provided here by Dr. Muhammad Barmania. We also wish you, on behalf of the Islamic Medical Association, a fantastic and a wholesome and a spiritual and a moral Ramadan, and also a healthy Ramadan. And to all of those that are ill, may Allah grant you shifa and make it easy, and all those that are healthy, may He keep you healthy, inshallah, and bring you closer to Him in this month of Ramadan. And we will close now with the dua of Surah Asr. والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. And inshallah we'll see you again next week, Saturday, Saturday afternoon slot for Health Matters, a comprehensive chat by the Islamic Medical Association. Assalamu alaikum wa rahmatullahi wa barakatuh.